Now we will go for the continuous meeting today. Today we got two sessions. The first session is a talk from Dr. Miniji Pillai from Amrita Institute of Medical Science. I invite Dr. Miniji Pillai on the dais. I also invite Dr. U Rajendran from RENAI MEDICITY to chair the session. Please come and proceed the session, sir.
This is a brief talk covering diabetes and hypothyroidism in general, not only treatment aspect. So this will be the basic flow of contents. Coming to the prevalence of hypothyroidism in type 2 diabetes, risk of hypothyroidism in adults with type 2 diabetes is around 10% in most studies, and risk factors for hypothyroidism are in type 2 diabetics are female sex, TPO antibody positivity, advanced age, and hospitalization, probably because more people are tested during hospital stay. Though recommendations say that when a person is hospitalized, especially with acute illness, thyroid function testing should be avoided unless thyroid disorder is specifically suspected. And in patients who have type 2 diabetes and are more than 65 years of age, the odds ratio of having hypothyroidism, it is more in males, 4.82 and versus 2.6 in females. And this is probably because females are, like, we always keep on checking ladies for thyroid dysfunction, so probably they are diagnosed earlier. And also in non-obese, in elderly it is more. Again, probably this is a bias because in obese people it is picked up earlier. And of course, TPO positivity, of course at all ages, if TPO positivity is there, thyroid dysfunction is more. And again, risk of subclinical hypothyroidism in type 2 diabetes around 10%, and prevalence of subclinical hypothyroidism in adults with type 2 diabetes versus healthy controls around 2-fold increased risk. Very complicated diagram. This is from Endocrine Reviews 2019. But to cut a long story short, basically thyroid hormone antagonizes the action of, we know thyroid hormone basically supports metabolism, it supports activity. Insulin tends to store fat in adipose tissue and liver, and store glucose as glycogen and fat, whereas in periphery, insulin supports glucose utilization. So thyroid hormone antagonizes the action of insulin in liver. It promotes gluconeogenesis, it promotes glycogenolysis, and in adipose tissue also it promotes lipolysis, because basically thyroid is an activity oriented hormone. So thyroid will antagonize the insulin action in adipose tissue and liver, and it supports insulin action in the periphery, that is in muscle. So these are the metabolic changes associated with thyroid dysfunction in type 2 diabetes. With hyperthyroidism, we expect increased appetite, increased food intake, increased glucose absorption, increased post-absorptive hyperglycemia, increased hepatic gluconeogenesis, increased plasma insulin and proinsulin, decreased serum cholesterol and triglycerides, increased hepatic insulin resistance, increased glucose utilization in muscle and adipose tissue, increased glucose intolerance, increased lipolysis and free fatty acids, decreased body fat, increased lactate production because glucose breakdown is enhanced, increased apoptosis of insulin producing cells, hyperglycemia, increased insulin clearance, deranged metabolic control in diabetic treated patients, increased risk of ketoacidosis, and increased insulin requirement in diabetic patients. And essentially in hypothyroidism, it is the opposite of all this. the points to note is that one is renal insulin clearance, that is decreased, so in hypothyroidism. So basically there is a proneness for hypoglycemia, that is one thing, and insulin requirement is decreased in diabetic patients. So generally in untreated hypothyroidism the insulin dose is decreased, and when you correct hypothyroidism the insulin dose requirement may increase. Now coming to subclinical hypothyroidism and type 2 diabetes, this is a systematic review meta-analysis. Type 2 diabetes was associated with an almost twofold increase in risk of subclinical hypothyroidism, and it can also affect the development of diabetic complications. Around twofold increase in everything: diabetic nephropathy, diabetic retinopathy, peripheral arterial disease and peripheral neuropathy. Around 1.5 to 2 times increased risk of all complications of diabetes. This is a study which looked at the effect of subclinical hypothyroidism on urine albumin creatinine ratio. A retrospective cohort study, small numbers. Basically it found that subclinical hypothyroidism is associated with an increased UACR in type 2 diabetes patients, and it is necessary to screen for thyroid function in type 2 diabetes patients and increase the follow-up frequency of UACR in patients with subclinical hypothyroidism. And again retinopathy also. This is a study which had around 200 patients, and around 100 patients had proliferative diabetic retinopathy, around 100 patients had non-proliferative diabetic retinopathy, and it was found that in patients with subclinical hypothyroidism they had older age, longer diabetes duration, higher HbA1c, higher insulin resistance and VEGF levels than in patients who were euthyroid. And the frequency of proliferative diabetic retinopathy was more in subclinical hypothyroidism, which means that probably subclinical thyroid dysfunction is accelerating the progression of diabetic retinopathy. It is associated with a more severe degree of diabetic retinopathy. And again increased VEGF levels were seen. So probably this increased vascular endothelial growth factor levels may be implicated in the relationship between subclinical hypothyroidism and diabetic retinopathy. Now the association of diabetes, subclinical hypothyroidism and carotid intima media thickness. This is again a very large study, a prospective cohort study, and in this cohort study actually they followed up. This is a very large study following up a very it is like the enhanced data, the enhanced data in US, a study from Brazil, large prospective cohort study. In this third follow-up of patients with subclinical hypothyroidism, they did a cross-sectional analysis, and they did analysis of a number of factors, and they showed that what they found is that carotid intima media thickness was associated with diabetes and also with subclinical hypothyroidism with diabetes. What they did is they did linear regression analysis with 2 factors in which subclinical hypothyroidism was combined with diabetes or hypertension or dyslipidemia or obesity, like all these risk factors for atherosclerosis. They combined subclinical hypothyroidism with each of these, and they found that when subclinical hypothyroidism was associated with diabetes, there is increased carotid intima media thickness. But though independently both subclinical hypothyroidism as well as type 2 diabetes was associated with increased carotid intima media thickness, the combination of 2 did not increase the risk or worsen the risk of this marker for atherosclerosis or coronary vascular events. This is basically a marker for vascular events. Vascular events as such were not studied. This is just a cross-sectional analysis. Now coming to the effect of anti-diabetic medications on thyroid function, we all know metformin, it lowers TSH in patients with high normal serum TSH levels, that is more than 2.5 to 3 in various studies, and also in patients with overt as well as subclinical hypothyroidism. So whether the TSH, it is in whether the thyroid dysfunction is in the level of overt hypothyroidism, subclinical hypothyroidism, or just high normal TSH, metformin has an effect on lowering the TSH level, and this is a reversible effect. After discontinuation, this effect is gone, and this effect can also be observed in diabetic patients with hypothyroidism when treating with T4. This actually, it is not relevant to us because none of us use the first generation sulfonylureas, but anyway it is associated with goiter. Second generation sulfonylureas do not have an effect on thyroid hormones. Thiazolidinediones, it activates the PPR gamma, as we all know, and that can stimulate the TSH receptor expression, and it can increase recruitment and differentiation of orbital fibroblasts and stimulation of adipogenesis and increase risk of goiter. Again, insulin, it enhances the level of free T4 and reduces the levels of T3. Basically, it inhibits the deadenase. It reduces the peripheral conversion of free T4 to free T3. It also has an effect on TRH and TSH secretion. So, the importance of screening for thyroid disorders in diabetes mellitus, hypothyroidism we saw, it is frequently observed in patients with type 2 diabetes, and many of these patients are asymptomatic even in the presence of overt hypothyroidism, and clinical symptoms of thyroid disease may be masked by a poor metabolic control, and poor metabolic control is more frequent in patients with thyroid disease. Undetected thyroid disorders may compromise metabolic control and amplify the risk of cardiovascular events in patients with type 2 diabetes. Screening of thyroid disease may allow early treatment, which will prevent high cardiovascular and metabolic risk. And now these are the recommendations for thyroid hormone screening from different associations. I think we will go straight away to our recommendations, that is RSSDA recommendations. This is from 2021 RSSDA guidelines. In patients with type 1 diabetes, anti-TPO test at the time of diagnosis along with annual TSH screening. In patients with type 2 diabetes, TSH screening at the time of diagnosis followed at every 5 years in individuals above the age of 35 years. And annual screening can be recommended in high-risk cases including patients with macrovascular complications, in patients who had subclinical hypothyroidism, who don't meet the recommendations for treatment of subclinical hypothyroidism in the first screening, probably we should do annual screening. Positive anti-TPO, we should probably do annual screening, and dyslipidemia. And these are a few risk factors of thyroid dysfunction in patients with type 2 diabetes: female gender, central obesity, diabetic nephropathy, uncontrolled diabetes, and long duration of diabetes. Now the algorithm for diagnosis and treatment: baseline evaluation with TSH and TPO antibody. If there is thyroid dysfunction, it can be overt or subclinical. Overt, of course, we have to treat. Subclinical, again, depending on the guidelines, we have to treat. So if TSH is very much suppressed in subclinical hyperthyroidism, appropriate treatment and monitoring. Again, this in diabetes also, it follows the general guidelines only. When coming to the treatment, a prolonged subclinical toxicosis, we have to do an etiological evaluation and treat. Whereas a very short duration, 6 months or 1 year, we can wait. But prolonged subclinical toxicosis, because it can cause loss of bone mass and can cause cardiac morbidity, we have to look at the etiology and treat. And again, subclinical hypothyroidism, TSH is more between 5 to 10. Consider treatment if persistent TPO antibody positive cardiovascular risk factors, goiter and rising TSH level. TSH more than 10, appropriate treatment and monitoring. Again, there is no difference from the routine recommendation for treatment of subclinical and hypothyroidism or hyperthyroidism, even if it is coexisting with diabetes. Again, coming to euthyroid on screening, if it is type 2 diabetes with antibody positive, monitor yearly preferably. Type 1 diabetes, annual screening is recommended. Impact on diabetes complications. We know hypothyroidism and metabolic syndrome, very close correlation. Both of them have very similar phenotype. Obesity, insulin resistance, dyslipidemia, hypertension, NAFLD, all of them causing increased cardiovascular risk. And hypothyroidism and again complications of diabetes, we already saw increased risk of nephropathy, which could be explained by the decrease in cardiac output and increase in peripheral vascular resistance in hypothyroidism, resulting decrease in renal blood flow and GFR. And treating hypothyroidism improves renal function. I am sure all of you would have seen overt hypothyroidism with TSH more than 150 and all at presentation. Creatinine is many a times slightly high, and this reverses with treatment of hypothyroidism. And more severe retinopathy than euthyroid patients. This already we saw a study. And again hypoglycemia also I mentioned already. There is increased risk for hypoglycemia in patients with hypothyroidism. Subclinical hypothyroidism, again, this is what we have mentioned already. Increased risk for microalbuminuria, increased prevalence of diabetic retinopathy and diabetic nephropathy. Cardiovascular events also significantly increased in type 2 diabetes with subclinical hypothyroidism. And even low normal free T4 levels are also significantly associated with increased insulin resistance. Again, CVD risk in hypothyroidism with type 2 diabetes, it magnifies, like this is only very, very logical. We know there is significant overlay between the pathology associated with hypothyroidism and with diabetes. So it magnifies the CVD risk through dyslipidemia and hypertension. Dyslipidemia with hypothyroidism is at least partly reversible with levothyroxine. And several studies have reported the interdependent associations between thyroid status, dyslipidemia and insulin resistance. And in euthyroid persons, low normal thyroid hormone levels were associated with dyslipidemia and insulin resistance. The risk of coronary heart disease in patients with type 2 diabetes, analysis of data from 803 patients without known heart disease at baseline. TSH levels within the reference range have a linear and positive association with CHD events, which means within the normal range, a higher TSH, it is associated with higher risk of coronary events. And of course, we know AF is more associated with lower. This is something which we have to be very careful when treating hypothyroidism patients. A chronically suppressed patient, TSH increases risk for AF. So especially as age advances, it is better to maintain TSH in a higher normal, like more than 2.5 or more than 3 range as age advances, when we are following up patients with overt hypothyroidism or any subclinical hypothyroidism, whatever, on levothyroxine treatment. We should take care as we follow up our patients. As age advances, we should become more lenient with the TSH levels, because long-term suppression, relative suppression of TSH increases the risk for AF, not only less than normal, even towards the low normal levels. Now, implications in management. Do these therapies for diabetes and hypothyroidism complement each other? The treatment with levothyroxine reduces HbA1c in patients with pre-diabetes and type 2 diabetes with coexisting subclinical hypothyroidism. So when we treat subclinical hypothyroidism in patients with diabetes or pre-diabetes, the HbA1c also may improve. And again, we saw the effect of metformin. When we give metformin in patients with subclinical hypothyroidism, overt hypothyroidism, in hypothyroidism already treated with levothyroxine. In all these scenarios, metformin has an effect of lowering the TSH. And again, this is very interesting. Effect of thyroid status on glycated hemoglobin with treatment. When you treat hypothyroidism, there is a marked improvement, significant improvement in HbA1c, whereas that effect is not seen with hyperthyroidism. Probably this is because the treatment of hyperthyroidism is not as smooth as treatment of hypothyroidism. So glycemic fluctuations also will be more. This we have already mentioned. Effect of metformin, sulfonylureas, thiazolidine-diones. Incretin mimetics. In animal models, it was seen that activation of GLP-1 receptors on thyroid C cells can cause increased release of calcitonin. There was increased C cell hyperplasia and increased risk of adenoma. But increased risk of medullary thyroid cancer was also seen in mouse models, in mice models at high doses. But in human studies, there was no effect on calcitonin levels or any reported malignancy. But still, caution is advised on treating patients with family history of medullary thyroid carcinoma or MEN syndromes with GLP-1 receptor analogues. Insulin has an enhanced level. This also we already covered. Recommendations for treatment. TSH levels should be monitored after beginning metformin treatment in diabetic patients with overt and subclinical hypothyroidism. There is insufficient evidence to recommend the assessment of serum TSH and free T4 levels and thyroid ultrasound in patients treated with sulfonylureas. Anyway, we are not using first generation sulfonylureas anymore. Pioglitazone should not be administered to patients with Graves' ophthalmopathy. GLP-1 receptor agonists are not recommended in patients with personal or family history of medullary thyroid carcinoma or type 2 MEN. Adjustment of insulin treatment should be considered in patients with diabetes after the occurrence of thyroid disease. The evaluation of thyroid function should be performed during ketoacidosis in patients with clinical symptoms and signs of hyperthyroidism or hypothyroidism. Glycemic control should be reassessed in hyperthyroid subjects after control of hyperthyroidism with ATDS. And increased insulin dose may be needed when starting treatment with LT4 in hypothyroid patients with diabetes. We saw there may be a reduced insulin requirement in patients with overt hypothyroidism. When this is corrected, insulin requirements are bound to increase. Excessive thyroxine therapy inducing TSH suppression should be avoided because it may induce iatrogenic hyperthyroidism, causing again impaired glycemic control. This is very, very important. Use of statins should be considered only after correction of hypothyroidism to prevent the risk of myopathy. This is a very commonly encountered problem. Even now, probably this is because not every physician attends CMEs. So, probably because of that, many times, even now we see patients with overt hypothyroidism. We know like people come with a package showing elevated TSH levels as well as all lipid levels, everything will be here and there, very high LDL, very high triglyceride. So thyroxine as well as statin is started together. The dyslipidemia may be due to hypothyroidism. Even if it is not due to hypothyroidism alone, it is dangerous to start statin in a patient with overt hypothyroidism. The risk of myopathy is very much high. So wait for treatment of, and we can also counsel the patient. We are not starting, you start diet, but statin we will start after the TSH becomes normal. So summing up, thyroid dysfunction and diabetes are closely linked. Several studies have documented the increased prevalence of thyroid disorders in patients with diabetes and vice versa. And untreated thyroid dysfunction can impair the metabolic control of diabetic patients, and this association can have important repercussions on the outcome of both these disorders. Thank you very much, and I would also like to invite you all to our first CENDOS update, which is happening next weekend, not this weekend, next weekend at Crown Plaza.
Talk on thyroid and diabetes, the interplay, the recommendations. And you have clearly outlined all these things in a very lucid manner. This thing is now open for questions. Any questions from the audience?
So, what do you say? How many days before the test you should stop metformin? That's number one. Second, you said it suppresses the TSH also. Is it really suppressing, or that's why is misinterpreted? If it is suppressed, then it is a benefit, T4 may be going up then. So what is it?
Sir, actually, it is a beneficial effect. It is not there is no recommendation to stop metformin at all before testing TSH. It is not practical also, but only thing is there is a very minor very minor variation only. But only thing is both these disorders are very, very common. So in a patient with TSH already in the low normal range or just below normal, if metformin is introduced, or vice versa, only in such scenarios we need to keep this in mind, not for all the patients.
It's not indicated in hypothyroidism, pioglitazone, any?
Not in thyroid disorders as such, only in ophthalmology. That is because of this PPR gamma effect, it increases the orbital fibroblast proliferation. It can worsen the Graves' ophthalmopathy. That is all. Not in any other thyroid.
Is it the same with the new molecule lobiglitazone?
I am not aware. But probably because the same mechanism of action is there. Only thing is PPAR alpha is also, I don't know whether that will make a difference.
So many patients ask whether to do thyroid test in fasting or after taking the thyroid tablet and come and do it later. So what do you suggest? What time is the ideal time in the day to do a thyroid test?
Nowadays, recommendation is to do in the morning. Actually, the study shows that meal does not interfere, but time, because all these hormones have diurnal variations. So it is better to do in the morning hours. So, and generally, like most of our people will have other fasting tests also. So nowadays, anyway, the study basically has shown that morning hours, basically TSH has a surge, morning hours. So we'll pick up the maximum TSH level in the morning.
Thank you, madam.
And meal can basically decrease the T4 level. So when we are checking TSH alone, it does not matter, but still the easiest is to recommend morning fasting because multiple tests will be there.
Just one more question. What is the ideal TSH levels to be maintained while on treatment?
For younger patients, there is no age-related cutoff as such. But personally, I prefer to maintain for younger patients below 2.5 to 3. But for older patients, like for patients who have more, like generally from 45-50 years of age, our risk for cardiovascular disease and all, markedly, like we are Indians, we are all Indians here. So we are prone for all metabolic syndrome related complications from 40-45 years onwards. So from that time, I generally try to maintain above 2.5, around 2.5. But again, within a narrow range of between 2.5 to 3, around that range would be ideal. In pregnancy, as we all know, like when a person is trying to conceive, we should try to maintain below 2 to 2.5, below 2 ideally.
Thank you, Dr. Mini, for that excellent talk and crowd interaction. I think we'll wind up the session.